Next, we'll begin our section on nephrolithiasis. We'll cover the etiology, treatment, long-term management, and metabolic acidosis in the setting of stone formation. As we get started, let's talk about some pearls of wisdom to help you answer questions on Step 2 regarding nephrolithiasis. The most common stone? Calcium oxalate, all the way. Next, what are the conditions in which calcium oxalate stones will form more frequently? The correct answer here is alkaline urine. Last, what's the most common risk factor for the formation of calcium oxalate kidney stones? The correct answer, overexcretion of calcium in the urine. So with that very brief introduction, let's go ahead and jump right in to a clinical vignette regarding nephrolithiasis, similar to one you might see on the USMLE Step 2. Here we have a 46-year-old man who comes into the emergency department with excruciating left flank pain that radiates to the groin. He also has some blood in the urine. The question for us is, what is the next step? Our answer choices are ketorolac, X-ray, sonography, urinalysis, and serum calcium level. The correct answer is A, ketorolac. Now this question is a bit tricky. You might be reading the clinical vignette, picking up on the classic symptoms of a kidney stone, and you might be tempted to pick one of these answer choices that would help you solidify your diagnosis. The important thing to remember here is that the question itself doesn't ask us for the next step in diagnosis. It asks us, what is the next thing to do? And when the diagnosis of kidney stones is pretty clear, based on the history and physical exam, it's important to first treat the patient. Kidney stones hurt. This guy is in 10 out of 10 pain, so it's important to give the patient some pain relief before proceeding with the rest of the workup. Now, ketorolac is an NSAID. It's got the benefit of being available both orally and in IV form. And even though it's not an opiate, it provides a really great level of pain relief on the same level as opiate medications. So now that we know that A is the correct answer, the rest of these answers are wrong for the simple reason that they don't treat the patient. Remember, it's best to provide pain relief in the setting of pretty clear diagnosis of kidney stones before ordering further diagnostic tests. Speaking of diagnostic tests, let's take a look at our next question. It asks us, what is the most accurate diagnostic test for nephrolithiasis? Our answer choices are CT scan, X-ray, sonography, urinalysis, and intravenous pyelogram. The correct answer? CT scan. CT scan has fallen into favor as the diagnostic test of choice for nephrolithiasis. It's great because you don't need contrast, and it's more accurate and sensitive than either an X-ray or a sonogram. X-ray has a 10 to 20% false negative rate, and it's important to know that not all stones show up on X-ray. Uric acid stones are the notable exception and can't be seen with regular plain films, but can be seen on CT scan. Sonography is also less accurate than a CT scan. What a sonogram is good for is really looking for the sequelae of a kidney stone. It lets you know if there is hydronephrosis or other evidence of increased pressure backing up from a urinary obstruction. Urinalysis can show hematuria, which is often present in the setting of kidney stones, but hematuria can also be caused by a lot of other things, so it's not the best diagnostic test for nephrolithiasis. Intravenous pyelogram used to be a good test for kidney stones, however, it's fallen out of favor, mainly because you need IV contrast to do an intravenous pyelogram, and in a patient with a kidney problem, you typically don't want to give a nephrotoxic agent if you don't have to. Also, it's not as good as the CT scan because it takes hours to perform and isn't as accurate. Remember, uric acid stones are not detectable on X-ray, but are visualized on CT. So the CT is quick, easy, not requiring contrast, and being able to detect all types of kidney stones make it the test of choice for nephrolithiasis diagnosis. So to review, if a patient comes in with acute renal colic, what do we do? The first step is to provide pain relief with good analgesic medication, such as ketorolac, as we talked about before. Second, hydrate the patient, either with PO fluids if they can take it, or with IV fluids. And third, order appropriate imaging to diagnose nephrolithiasis, the best test being a CT scan without contrast. Now, not all kidney stones are treated equally. Cystine kidney stones are one special exception. They're best treated with surgical removal, and alkalinizing the urine can help them pass. As certain types of kidney stones have specific treatments, it's important to determine the etiology of the kidney stone. One way to do that, if the patient actually passes the stone or it's removed surgically, you can perform a chemical analysis to see what the stone is actually comprised of. Additionally, you can do some serum studies to help give you clues as well. Serum calcium, serum sodium, uric acid levels, parathyroid hormone, magnesium, and phosphate levels can all be useful. A 24-hour urine collection is often performed to get an idea of the volume of urine passed in 24 hours, also calcium content, oxalate content, citrate, cystine, pH, uric acid, phosphate, and magnesium. These can all help us make the diagnosis of what type of stone is present. Finally, fat malabsorption also increases stone formation. This is why a lot of surgical patients who have had to undergo an extensive bowel resection are more likely to experience kidney stones. Let's now take a look at another clinical vignette. Here we have a woman who has her first episode of renal colic and is found to have a 1.8 centimeter stone in her left renal pelvis. There's no obstruction noted, and her BUN and creatinine are both normal. So what's the question? What is the next step in management? Our answer choices here are to wait for it to pass, just hydrate and observe, perform lithotripsy, perform surgical removal, give hydrochlorothiazide, or place a stent. So, looking back up to the question, you know they didn't tell us it was 1.8 centimeters for no reason. The size cutoff should help guide what treatment we're going to choose for nephrolithiasis. So with a size of 1.8 centimeters, what's the best treatment? The correct answer is lithotripsy. So lithotripsy is the treatment of choice for stones anywhere in size between 0.5 centimeters and 2 centimeters. Additionally, stones that are either halfway up the ureters or higher are often treated with lithotripsy. Lithotripsy is the administration of sound waves to the external surface of the body that breaks up the kidney stone where it lies within the body. It breaks it up into smaller fragments, and those smaller fragments are more likely to pass. So now that we know why B is the correct answer, let's take a look at the other answer choices. A. What size stone would it be appropriate to just sit and wait for it to pass with conservative measures? The correct answer here is less than 5 millimeters. So if a stone is less than 5 millimeters, it's more likely going to pass on its own. So all we need to do is support the patient, keep them comfortable and hydrated until that happens. For C, surgical removal, this is only indicated if the stone is greater than 2 or 3 centimeters. Although this patient's stone is pretty close at 1.8, it doesn't meet that cutoff of 2 centimeters to require surgical removal. D, hydrochlorothiazide, this medication acts to decrease the calcium in the urine, which is good in a patient who's predisposed to kidney stones because it might help prevent new ones from forming. However, it's not going to do anything for the 1.8 centimeter stone that's already there. Lastly, stent placement. Stent placement is often done in patients with kidney stones, but only if there's some evidence of obstruction or hydronephrosis. We don't need to place a stent in this patient because we're told she has no obstruction, and her normal BUN and creatinine indicate that she doesn't have any post-renal acute kidney injury. On the whole, approximately 50% of patients who have kidney stones will suffer a recurrence within the next 5 years. As we talked about before, not all kidney stones are created equal, and certain kidney stones are going to arise in certain situations. The most common example of that is the struvite stone. Struvite stones are comprised of magnesium, ammonium, and phosphate, and those are typically found in the setting of a UTI with a urease-positive bacteria. These are typically very large. They can be staghorn calculi, and they must be removed surgically. Let's take a look at another clinical vignette. We have here a man with a calcium oxalate stone, and he's managed with lithotripsy. The stone is destroyed and the fragments pass. Urinary calcium level is found to be increased. Besides increasing hydration, which is most likely to benefit this patient? Our answer choices are calcium restriction, hydrochlorothiazide, furosemide, stent placement, or increased dietary oxalate. The correct answer? Hydrochlorothiazide. Hydrochlorothiazide is a great medicine for patients with calcium-containing kidney stones because it removes calcium from the urine, increasing reabsorption into the bloodstream at the distal tubule of the nephron. It's been shown to decrease the recurrence of kidney stones if we can keep the calcium levels of the urine low. Now we know why B is correct, so let's take a look at why the other answer choices are wrong. Calcium restriction sounds like a good idea, but actually, dietary restriction of calcium can lead to increased rates of oxalate kidney stones. This happens because calcium binds oxalate in the bowel, and when we're not ingesting enough calcium, there's increased oxalate absorption from the gut into the bloodstream and can lead to precipitation of oxalate kidney stones. Furosemide is the absolute wrong answer to this question. Remember from your pharmacology days that hydrochlorothiazide and furosemide have opposite effects of urine calcium. Whereas hydrochlorothiazide decreases urine calcium, furosemide increases urine calcium, therefore actually increasing the risk that a calcium-containing kidney stone might form in the future. Stent placement, again, this is only going to relieve obstruction. Since this patient had a stone, it was destroyed and passed, there's no evidence of obstruction, placing a stent isn't going to help anything and will only increase complication rates and morbidity. Lastly, increased dietary oxalate. This is wrong because just like decreasing calcium in the diet, increasing oxalate in the diet can increase the rate of oxalate stones. Patients with metabolic acidoses are well known to be at higher risk for kidney stones. That's because the increased protons in the blood leads to calcium leaching from the bones. Increased calcium levels in the blood means there's more calcium available to form stones. Additionally, metabolic acidosis has the effect of decreasing citrate levels in the blood. In normal patients, citrate serves to bind calcium and make it largely unavailable to form stones. So in metabolic acidosis, with decreased citrate, there's increased unbound calcium, leaving it wide open to form stones and cause the patient problems with nephrolithiasis. Now let's shift gears and talk about the two major types of urinary incontinence. The difference between stress and urge incontinence are highly tested on the USMLE Step 2. The difference in symptoms is key because it will help you read through a clinical vignette and make the correct diagnosis. If the clinical vignette is trying to point you in the direction of stress incontinence, they will often describe an older woman who has painless leakage of urine when she's coughing, laughing, or lifting heavy objects. In contrast, a patient with urge incontinence will experience a sudden pain in their bladder followed immediately by the overwhelming urge to void. You diagnose these two types of incontinence with different testing as well. The test for stress incontinence is actually to directly observe the leakage of urine when the patient does something that increases their intra-abdominal pressure, such as standing upright and coughing. The diagnostic testing for urge incontinence is a little bit more objective. You can actually use manometry, which uses a transducer to measure pressure when the bladder is half full. In patients with urge incontinence, the pressure will be higher than in a normal person with the half-full bladder. Telling these two conditions apart is important because the treatment is vastly different. Stress incontinence is first managed by teaching the patient how to perform Kegel exercises, whereas urge incontinence is treated with behavioral modifications including bladder training exercises. These exercises basically include frequent, scheduled trips to the bathroom to avoid that sudden urge to urinate. For pharmacologic therapy, local estrogen cream is used to treat stress incontinence, whereas anticholinergic therapy is prescribed for patients with urge incontinence. Specific medications that can be used are oxybutynin, tolterodine, solifenacin, and darafenacin. For surgical therapy, actually tightening the urethra can be beneficial for both stress and urge incontinence. This concludes this section.